Today I would like to talk to you about the evidence that we have with regard to the causality of LDL, the evidence we have for setting targets for its treatment, and also to look at the overall goals of therapy. This slide summarizes the coalescence of evidence from multiple sources that LDL is actually the smoking gun, the culprit of atherosclerosis, whether it's from pathology, epidemiology, intervention trials or genetics. There's a consistent story that appears that LDL is indeed causal. The nature of the causality is that it is linear over the range that we have looked at. Here's a trial summarizing the achieved levels of LDL in both primary and secondary prevention trials, adjusting for the different risk. And you can see a clear dose response between achieved LDL in the placebo or the treatment arms of each of the trials and our experience of the risk associated with that certain level of LDL. The question until recently was, what happens when the LDL goes ever lower? Is there a J-shaped curve, as is true for glucose or hypertension, or is it actually a straight line all the way down almost to zero? And the answer is, of course, that we now know from Fourier, Odyssey outcomes, and Improve It, that we have a straight line all the way through. So there's no flaw that we can see in terms of the ability to reduce risk alongside the ability to reduce LDL. This is primary evidence of the causality of LDL and coronary heart disease. Further evidence comes from other trials that have been done, including trials with CETP inhibitors like HPS3 Reveal, and also here Fourier and ezetimibe. So it's not just statin trials that provide the evidence, but also the non-statin studies, which by their nature have been done in people who have already got very low LDL levels and are reducing them even further. So in this slide you can see that metaregression suggests that all the way down to levels of 0.5 millimole, there is still a benefit to be obtained from lowering LDL. On the other side, the data also suggests there is no safety signal or adverse event that is emerging from these studies. So we seem to have a very toxic molecule in terms of LDL that we can reduce as far as we want to without actually paying a price in terms of safety. So when we come to look at targets, I would like to make the point that usually a target is set as the balance between benefit in terms of reducing the risk factor, offset against the detriment if you lower it too far. But that's not the case for LDL. We actually have a situation where we could lower it to zero if we wanted, and we would see no disbenefit, no disadvantage. But that's not practical in terms of setting targets or decision points for case studies and also for treatment. So the targets that are set in the new European guidelines and the AHA guidelines are based on the risk status of the individual, whether or not they then receive more aggressive statin therapy, and what we're trying to achieve in terms of a target. And importantly now, in the latest manifestations of these guidelines, when you get to a target of about 70 milligrams per deciliter in a high risk or very high risk individual, secondary prevention, the idea is that you move to combination therapy with ezetimibe or with PCSK9 inhibitors in order to achieve that level that we've been talking about, which is as low as possible. And also in these individuals, we are looking for more than a 50% LDL reduction, which has to be achieved usually with combination therapy. So, what is the evidence that we are actually achieving these goals? If we say that the goal is to deliver optimal LDL treatment for each patient tailored to their needs, then we see that there is actually an experience from recent publications that individuals are not taking high intensity statin therapy as they should. Only about 1 in 2 are being put on high intensity statin therapy by their cardiologist. And there's a resistance from the public in terms of going on the high dose of these drugs. And this was seen in recent publications where the lack of conviction by physicians, particularly primary care physicians, that they should go towards high-intensity statin therapy, and an aversion to high doses from the public have led to a very large gap between what the guidelines say and what practice is actually about. And therefore, to achieve our goals of therapy, which is a successful treatment of coronary prevention in individuals who are at risk because of raised LDL levels, the suggestion is that we have to take into account patient preferences. What are the perceptions of the patient with regard to benefit, safety, and tolerability? We need patients to adhere to therapy, and therefore persistence is a key feature. And we also need to personalise the approach, because everybody will be different with regard to the biomarkers, the risk enhancers, the overall risk profile of an individual as to where you then set that target. Thank you.